And thanks to Nats for also arrangements. So, as I mentioned, we've got lots of speakers, so I'm not going to talk to you about everything you need to know about antivirus. I'm not even going to talk to you about the treatment. I'm going to try and focus on some new developments in areas where I think.
Yeah, he's recording.
And some of it I'll go over very quickly because it's going to be covered by other people. Okay. So, I've been doing this kind of talk ever since I was a consultancy, which is like 17 years now. And this slide is the same time as I did on my very first talk. The message hasn't really changed, so that the cornerstone of treatment of AS is early accurate diagnosis, which we are getting better at with new imaging modalities. We still often take time. And effective patient education, which is what that means to. And although we have got some exciting new drugs, which I'm going to talk to you about, much of the treatment of AS remains lifestyle and non-drug treatment. And so we try to facilitate this by clear descriptions of what you can do to help yourselves, backed up with written material. And you will be aware of lots of general measures that can help with spondylitis, like a suitable bed, workstation adjustments and so on. And it remains, and I'm not just saying this because I'm standing in the physiotherapy department, but I think it is still true that physical therapy is still the single most important aspect of treatment of AS. So regular daily exercise. And that starts with a period of education. And just out of interest, have we got many family members here? Yeah, so that's great. Good. So I'm sure Adam extends the invitation to all education staff to family members, which is going to be very helpful. Occupational therapy has a role as well, and I've always said that smoking is bad for people with AS, but since we're talking about recent developments, in the last few years there has been certain greater emphasis placed on this, and that smoking is a risk factor for getting AS. And if you have AS, it's a risk factor for severity of disease as well. So, which is very interesting. So we've always known it's a bad thing because of the chest and so on, but smoking appears to be a particularly risky thing to do if you have AS. So the next few slides I'm going to go through very quickly, not because they're not important, but because Ali, who's speaking after me, is going to spend a bit more time. But the drug treatment of AS, we start with a simple painkiller, such as paracetamol, codeine paracetamol mixtures, such as methadone, dihydrocodone, tramline. I think I won't say any more about that because Ali, you're going to talk a bit about that.
Yeah.
Second group of drugs, anti-inflammatory drugs, non-steroidal anti-inflammatory drugs, such as naproxen, ibuprofen, indomethacin. So another change that I've made to this talk, a recent development, is diclofenac. So that's Voltarol, a drug that we used to use very widely, and it is still used, and it's actually a very good anti-inflammatory. But there's been a recent suggestion that it may have slightly more side effects than some of the others. So I don't know if any of you have experienced this, but a lot of GPs have had to take people off diclofenac, suggesting naproxen instead. More than happy to address that if you want to. And again, I'm not going to talk about how they're used, because Ali will be talking about it. The third group of drugs that have been around for some while managing AS are what we call disease-modifying drugs. And these are drugs that we've borrowed from rheumatoid arthritis. So they were drugs that were established and effective in rheumatoid arthritis. And these are drugs like sulfasalazine and methotrexate. Anyone here want any of those?
Methotrexate, but actually for uveitis rather than for
Okay,
AS.
okay, thanks.
I used to start.
Okay, thank you. Great. So the traditional teaching is that they may be helpful if you get peripheral joint involvement, like hip, the shoulder, elbow, and they're less helpful for the spine. Actually, it's just that no one's really looked at them in great detail in the spine. They may have more of a role than we used to think, but they certainly tend not to be used very widely for the spine because we've got newer drugs. But these drugs, unlike the painkillers regularly if you're feeling fine, or monitoring. And finally, group of drugs before we talk about the brand new ones, steroids. So steroids can have a role in ankylosing spondylitis. Probably the best, most effective use is if you get a problem like a knee or a hip, and then injecting steroid directly into the joint can be very helpful. Or injections to something called the epithesis, which is things like plantar fascia or Achilles tendon. You can sometimes use steroid tablets, or if people are having a really bad flare-up, you sometimes give a drip intravenous steroids. And they can be useful for flare-ups. So, Adam asked me to talk about what's new. And I guess, although these aren't particularly new, these are the main drugs that I really need to make sure you've heard about. And these are drugs called anti-TNF drugs. TNF stands for tumor necrosis factor. It's a chemical that we've all got. It's normal to have it. It's part of the body's immune response and causes inflammation. Now sometimes, of course, inflammation is a good thing. If you get an infection, you want inflammation to fight the infection. But in the late 1980s and early 1990s, workers actually looking at rheumatoid thought that tumor necrosis factor seemed to be one of the most important chemicals in terms of the inflammation of ankylosing spondylitis. Various experiments showed that. So then, sort of went through the process, they developed true designer drugs. They said, okay, we think this chemical is what drives inflammation in AS, in rheumatoid, sorry, but it then transferred to AS. So let's design a drug to block them. So they did that and designed antibodies to block this chemical, anti-TNF. Just a bit of a timeline. So they were licensed for use in AS in 2003, in rheumatoid for about 2001. National Institute for Clinical Excellence, NICE, issued their guidelines in 2008. And these are drugs like etanercept, adalimumab. Anyone here taking those drugs at the moment? Sam was one of the first patients to go on. Do you remember when you were first put on this?
2010, something like that.
So, these drugs are not, it's a bit complicated, but they're not synthesized in a test tube in chemical here and chemical there. They're actually antibodies, and so we use bugs to make these antibodies. So they're grown in living systems. And that's why this type of drug has acquired the name biologic therapies. You may hear that term used. Biologic therapies. They're all given by injection, none of them are tablets. NICE has issued guidelines as to when these drugs should be used. And essentially, you must have tried other treatments and have a certain level of disease severity. Here in MBT, we're really lucky to have a great team managing our patients with AS on biologics. That team is Adam and Adam. Both of whom are here, both of whom I'm sure you've seen if you're taking these drugs. And we're really lucky we've got a very, well, I like to think, a very efficient system for seeing people when they need to be seen, getting people on these drugs, and monitoring them appropriately. And so we have a system whereby when patients are stable, they're seen every 6 months, alternated by Adam and Ali, and 6 months later by the consultant, and years later, 6 months later by Adam, and so on. It is obligatory for us to see patients on these drugs. One of our problems is that sometimes patients feel so well on the drugs that they say, I don't really need to come up to the hospital. But we do need to see you, partly to fulfill the requirements that NICE lays down, and partly just to check that you're still responding. So we ask people to come every 6 months. And another sort of area of interest at the moment is what do we do when people have been on these drugs for several years and appear to be stable, is there any option, scientists keeps popping up, is there any option to begin to reduce the dose? I mean, do you usually do that by extending the interval between injections? And it's an area that I think has a lot of things going on. Everyone's different, of course, but there are some patients who will say, well, instead of having it every 2 weeks, I sometimes even have it every 3 weeks, and that seems to be enough for me. That seems to make sense when people are stable. These drugs are often very effective. Not in everyone, but in about 70% of people, these are very effective drugs. They work relatively quickly, 2 to 12 weeks. And their main benefits are pain, stiffness, and head function. We don't at the moment have any evidence that they have any long-term effect. So there isn't really, a lot of people will ask this, but there isn't really any logic in people who are feeling very well saying, well, should I use these drugs to make me well in 10 years' time? In rheumatoid, there is some evidence, but in AS there isn't. So they're used exclusively for current symptoms. And it's very important not to forget other treatments, like looking after your back, doing your exercises, taking painkillers and antifungals if you need them, when you're on these drugs. These are additions, they're not substitutes. They aren't for everyone, so they're not suitable if we're not absolutely sure of the diagnosis. If the disease is mild, as I've said before, there isn't any indication for these drugs. So it has to be moderately severe by the sort of grading system that would be from measures of pain, stiffness, and mobility. You've got to have tried anti-inflammatories first. In general, we don't recommend them if there's a history of cancer in yourself, individual, or TB. A pregnancy, that's for a question mark against that. Traditional teaching until about 2 weeks ago was you shouldn't use these drugs if you were planning to become pregnant. Now, we've had an interest in this department and looked at the data over the last couple of years and not been convinced that there's any evidence of any problems. 2 weeks ago, British Society of Rheumatology amended its guidelines to say that these drugs could be used in women who were attempting to become pregnant. It's still something that we would always encourage women to talk to Ali or Adam or their consultant about, because there are other issues, but I think it's fair to say that they're no longer contributing. What's going on?
Yeah.
Generally, I think these drugs are well tolerated, but people can get problems like injection site reactions as when the injection is done. People can feel generally a bit flu-like. There is an increased risk of infection with these drugs, particularly TB. Just this morning, I saw this patient who has AS and started anti-TNF therapy and presented unwell with this chest X-ray. I don't expect you to be an expert in interpreting chest X-ray. If I tell you that this is the lung and it should be black because it's air, you might see that it's a bit white. There's a few speckles scattered throughout the lung. And this poor chap's got widespread TB. So it does happen, but it's very rare. But that's why we will always ask for a history of TB and we do a chest X-ray as a baseline. But it does happen. There is a theoretical risk that these drugs may be associated with a risk of cancer. As I said, we've all got TNF. It stands for tumor necrosis factor. And part of their role in us all is if we all, well, most of us do, develop tiny little cancers, and the body recognises and destroys them. So we never do that. And part of the body's system includes this chemical. So the theory is, if you block this chemical, would you allow cancers to develop? So it's theoretical. And at the moment, we still don't want these drugs to people who have cancer themselves. I have to say that we are watching this with great interest, we within the whole national rheumatology community. And so far, signal is looking extremely reassuring. So we are not seeing any increase in cancer. But it does remain a theoretical concern. Another complication is a rare triggering of another disease called lupus. Again, very rare. The other point I just have to say, as you've seen from my timeline, that we haven't been using these drugs for very long. So we don't really know what the long-term side effects are using them. Although they're long-term side effects. And you can't have certain vaccines. The live vaccines, such as shingles, yellow fever. So that's about it. The anti-TNF drugs are currently the only biologic new type of drugs that we've got for AS, which is a shame, because in rheumatoid we've got about 4 others which block other inflammation chemicals. So if people with rheumatoid fail this drug, they can go on to one of the others, and they can go on to another, but they don't work in AS1, unfortunately. So that's all we've got at the moment. There are other ones coming along, targeting other markers of inflammation that seem to be important in AS, but they're not available yet. And other areas of research at the moment are looking at why smoking is so bad for AS. What is it about it that seems to trigger worsening the disease? There's also some interest in anti-inflammatories. There's just been a couple of studies that suggest that anti-inflammatories, although they can have side effects, may have some kind of long-term benefit. We're not recommending people take handfuls of them even if they don't have any pain, but we're looking at why that it might have some sort of long-term effect. And then finally, there is now a sort of resurgence of interest in diet, and really that's as a sort of precursor to what's called the bioflora. So that's all the bugs in our gastrointestinal tract. There's been some interest in this on and off over the years. People have always talked about certain diets and so on. But that is an area of current active research. It's just nightmarishly complicated. Just trying to measure all the bugs that are in our bowel. It's an awful lot. And trying to work out which ones might be important and so on. It's a hugely complicated area. But I just mention it because it is an area that's active research. That's all I've got to say, but if anyone's got any questions, I'll be more than happy to answer.
Recently I watched a program, it was on MS, and it's around bone marrow transplant.
Yeah.
And I don't know, but as far as I know, it's similar. What it is a kind of inflammation because of antibodies and stuff.
Yeah.
So is there anything happening in that?
I don't know of anyone who's looking at that. And it may be because the anti-TNF drugs have been, or I'm obliged to paint the dairy side as well. In general, they have been very, very effective. So people haven't really felt the need to look at potentially life-threatening procedures like bone marrow transplant. It is very different in MS, where there are still a big lack of good drug therapies, and people die of MS. People don't usually die of transplant, so there isn't quite the same rationale for putting something through a really bad procedure. But it's an interesting area.
Any other questions? Anybody wants to ask?
In terms of the diet stuff, you say it's sort of starting to do more research. Is there anything out there that is nothing at the moment?
Okay, so there is people sometimes say, yes, there is a diet that patients with MS should be on, but it's the same diet we should all be on. It's a healthy diet. We all know, don't we should eat more fruit, vegetables, and less processed food, less sugar, and less saturated fat, and so on. There is quite good evidence for one particular branch of that, which is switching to unsaturated fats, so like oil or primrose oil instead of butter, or fish oil, something like that as well. And they do have a sort of anti-inflammatory effect. It's just not very powerful, and you've got to take an awful lot of, say, fish oil capsules to get the effect. So that's the sort of standard diet. In terms of more radical things, like taking things like Yakult or natural yogurts and things, there's no evidence. But, there's unlikely to be any downside. And so if people want to try things like that, they're probably quite good for us anyway, then there's no real downside. But because those are full of hundreds of different bacteria, so if you did feel better, which one was it? And it may be different for everyone. And also different at different stages of the disease. That's another problem. These bacteria may be important before we even get symptoms. Trying to study that makes it very difficult, but they may be important even before we get symptoms.
Lovely. Anything else? Fantastic.
Thanks for your attention.
So, thank you. As I like to switch things, I'm going to switch the order ever so slightly. So I'm going to introduce you to Ali, who's one of our specialist nurses here, again, who I work very closely with. She's going to do a little bit on the medical management, which fits in there quite nicely, and then I will cover the physio bit.